So this is the second lecture of pregnancy-induced hypertension, where we will discuss the etiopathogenesis. There are certain etiopathogenesis. Various theories have been put to explain why PIH occurs, but none of them fully explains the mechanism. Any theory concerning the origin of preeclampsia must account for the observation of the GTN and gestational hypertension. Preeclampsia is more common in women with the following characteristics. So these are the high risk female, means the exposure of chorionic villi for the first time, means a primary gravida female. More common in females with abundance of chorionic villi, means females with twin pregnancy, pregnancy induced hypertension, and twin pregnancy and Rh negative pregnancy, etc. In females with pre-existing conditions with endothelial activation like SLE or APLA and genetic predisposition. Fetus is not a prerequisite for preeclampsia to develop. Although chorionic villi are needed for the development of PIH, it is not necessary that chorionic villi should be intrauterine. Even in case of abdominal pregnancy or extrauterine pregnancy, preeclampsia can occur. Now, what is the etiology? Amongst the suggested mechanism to explain preeclampsia, the main ones are: first, the placental implantation with abnormal trophoblastic invasion of spiral arteries, means there is abnormal trophoblastic invasion. Second is abnormal immune tolerance between mother, placenta, and the fetus. Mother's own maladaptation to cardiovascular changes and inflammatory changes, which occurs normally during pregnancy. Genetic factors and environmental factors. So, genetic factors, environmental factors, maladaptation to the certain changes in pregnancy, immune tolerance, and then there is abnormal trophoblastic invasion, which is most important. Now, Rahman and co-workers describe preeclampsia as a two-stage disorder theory. The stage 1 includes the placental syndrome, while the stage 2 includes the maternal syndrome. What is placental syndrome? Placental syndrome is caused by the defective remodeling of spiral arteries by the endovascular trophoblast, which eventually leads to the stage 2. Now, what is stage 2? Stage 2 in which there is there is maternal syndrome. Maternal syndromes means manifestation are going to occur in the mother in this stage. Now, there are certain aggravating or modifiable factor for pre-existing maternal conditions which can aggravate the symptoms of the mother. These are the obesity, renal diseases, history of diabetes in the mother, immune disorders, and the connective tissue disorders. Now, what is the physiology of trophoblastic division? So, this trophoblast, which is formed at day 8 of fertilization, is divided into two parts. That is, first is the cytotrophoblast and the syncytial trophoblast. This syncytial trophoblast, its function is to form the hormone, and it is known as the hormone factory of the placenta, while the cytotrophoblast is divided into villus trophoblast and the extravillus trophoblast. This villus trophoblast comprises of chorionic frondosome, which is the fetal side of the placenta, and chorion leve, which are the maternal side of the placenta, while the extravillus trophoblast makes the interstitial trophoblast and the endovascular trophoblast. Now, coming to detailed placental syndrome explanation. Normal placental implantation is characterized by remodeling of the spiral arteries in the placental bed. The endovascular trophoblast means this trophoblast. This extravillus trophoblast, which is the part of cytotrophoblast, helps in remodeling of the spiral arteries. So it lines the decidua and the myometrial part of the spiral arteries, and the lining is replaced by the endothelial and the myometrial lining. This occurs in the placental bed. This remodeling happens to convert spiral arteries from high resistance to the low resistance vessels, and this is done by enlarging the diameter of the spiral artery such that the artery remains constantly dilated and becomes resistant to the vasopressors. This process is called as the trophoblastic invasion. These veins are invaded by the trophoblast only superficially. Now, this trophoblastic invasion also occurs in two phases, phase 1 and phase 2. Phase 1, where decidual part of the spiral arteries is replaced, and it occurs before 12 weeks. While phase 2, where the myometrial part of the spiral artery is replaced by by this trophoblast, and this occurs between 12 to 16 weeks. So, the period between 12 to 16 weeks is very important. In the patients of PIH, this phase 1 occurs, but the phase 2 does not occur, or if occurring, then it is incomplete. So this image is about the trophoblastic invasion that occurs in a normal pregnancy. These are the spiral arteries, and this is the decidual part of spiral artery, and this is the this is the myometrial part of the spiral artery. Here, there is trophoblastic invasion of the decidual part, which occurs in the phase one, and this is not occurring in this. And this is not occurring in this part. So this is a non-pregnant decidua where there is no trophoblastic invasion. Here there is trophoblastic invasion of the maternal spiral artery, but it is occurring only in the decidual parts, and there is complete decidual as well as myometrial trophoblastic invasion that occurs in normal pregnancy. So these are the lining of the spiral arteries, and this invasion leads to increased caliber and vasodilation of the spiral arteries. Now, how trophoblastic invasion occurs? Endotrophoblast first enters the lumen of the spiral arteries. It forms the cellular plug. Then it destroys the vascular endothelium by apoptosis, and there is invasion and modification of the tunica media. The fibrinoid material replaces the smooth muscle fibers and connective tissue of the tunica media, and later there is regeneration of the endothelium. Why this fibrinoid material is getting replaced? Because this fibrinoid material is not responsive to the vasopressors. The artery remains dilated and the blood flow remains in the placental bed. These changes are only seen in the decidua bassalis and not in the decidua parietalis and decidua vera. So these changes are only seen in decidua bassalis. Now what occurs in the patients of preeclampsia? The primary wave is complete, but the secondary wave, that is phase 2, is not complete, and the decidual part is replaced by the endovascular trophoblast, while myometrial segment is not, known as the incomplete trophoblastic invasion. And the deeper myometrial arterioles do not lose their endothelial lining and muscular tissue. As a result, their external diameter is only half of that of the normal pregnancy. The magnitude of defective trophoblastic invasion correlates with severity of preeclampsia. Means magnitude of trophoblastic invasion is directly proportional to the severity. So if this leads to abnormal narrowing of the spinal arteries, and there is blood supply reduction to the placenta, which leads to hypoxia and placental ischemia. This placental ischemia is known as angry placenta, and this leads to gestational hypertension, pregnancy induced hypertension, IUGR, preterm labor, and abruption. Now, what are the features of ischemic placenta on electron microscopy? This small pale looking placenta with following characteristics can be seen: with endometrial damage, myometrial proliferation, atherosclerosis due to lipid laden macrophages, there is fibrinoid necrosis, there is thrombosis in the blood vessels of the placenta, there is placental arterial sclerosis, and placental infarcts are also seen. Now, what is the difference between a happy placenta and an angry placenta? In happy placenta, both phases occur, while in angry placenta, only first wave occurs. TH2 to TH1 shift is seen in angry placenta, while is not seen in angry placenta, while this shift is seen in happy placenta, where T helper 2 cells are more than comparing to T helper 1 cells. The resistance is high in angry placenta, and the diameter is almost half. There is immunotolerance to paternal and fetal genes occurring in happy placenta, while there is no immune tolerance to paternal and fetal genes, and there is increased sensitivity of angiotensin 2 also. This angry placenta leads to stage 2. Stage 2 is the maternal syndrome, where there occurs the symptoms of this abnormal trophoblastic invasion. Immunological and genetic factors also play a role in the etiology of pregnancy induced hypertension. Now, what is stage 2? Stage 2, also known as the maternal syndrome, where this angry ischemic placenta in the maternal circulation could release the anti-angiogenic factors like SFLT1 and serum and soluble endoglin 1 protein, vasoconstrictor, infertility, inflammatory mediators are released, and there is decrease in vasodilators and the angiogenic markers. So anti-angiogenic markers and vasoconstrictors are high. This ischemic placenta can also increase sensitivity to vasopressors like norepinephrine and angiotensin 2, and the two most important angiogenic factors, as we have already discussed, are soluble FMS like tyrosine kinase 1 and soluble endoglin 1. Now SFLT1. This SFLT is anti-angiogenic, means it decreases and inactivates the vascular endothelial growth factor and placental growth factors. So this decreases VEGF and PIGF, that is placental growth factors. These are the angiogenic factors, and in this way this leads to endothelial dysfunction, endotheliopathy, and endothelial cell abnormality. So, in such patients with high risk of preeclampsia, we can calculate the SFLT1, and if the level of SLT1 is twice, then there is 40% risk of having pregnancy induced hypertension. Now, what is the function of soluble endoglin 1? This decreases the binding of transformation growth factor beta to its receptor, and in this way, this leads to a decrease in nitric oxide, which is a potent vasodilators, and eventually leads to vasoconstriction. If the soluble endoglin levels are increased, the risk of preeclampsia is 70%. So, it is more sensitive than SFLT1. SFLT1 and soluble endoglin levels are raised in the maternal circulation. They are not raised in amniotic fluid and fetal circulation. Hence, they can be checked in maternal serum test. Their level decreases after delivery, hence definitive management is termination of pregnancy. Now, what is nitric oxide? This is a potent vasodilator which is synthesized from the amino acid arginine by the endothelial cells. Decrease in nitrous oxide means mean arterial pressure, heart rate, reversal of pregnancy induced refractoriness to the vasopressor, and effect of VEGF and platelet growth factors is decreased, and this mean arterial pressure and the heart rate is increased in these patients. Now, what do these vasoconstrictors and vasodilators do? The vasoconstrictors like SFLT, soluble endoglin increases, thromboxane A2 increases, while the prostacyclin decreases. Thromboxane A2 is a vasoconstrictor, while prostacyclin is a vasodilator. TNF alpha endothelin 1 increases, and the sensitivity to angiotensin 2 also increases. PGI2 to thromboxane A2 levels decreases. VEGF, placental growth factor, nitric oxide also decreases. Since thromboxane A2 increases, aspirin is used to prevent pregnancy induced hypertension, and in patients with pregnancy induced hypertension, functional and autoantibodies develop against endoglin and angiotensin 2 receptors, and these are the stimulating antibodies. Hence, if this thromboxane A2 is increasing, and we are using COX2 inhibitor, which is an aspirin, and this aspirin can decrease thromboxane A2 levels, and hence help in reducing the incidence of pregnancy induced hypertension, and can be used for prevention also. Now, due to the imbalances between the vasoconstrictors and vasodilators, there is formation of free radicals, which leads to endothelial injury and hence increase the capillary permeability, which can cause the edema and hemoconcentration, production of lipid-laden macrophages, also known as the foam cells, that can lead to atherosclerosis. The vasospasm can raise the BP of the mother, which is the first clinical manifestation of pregnancy-induced hypertension. So, this increased capillary permeability can cause accumulation of fluid in the third space, causing edema, and inside blood vessels can cause hemoconcentration. In kidney, the increased capillary time causes proteinuria. The first manifestation is raised BP. When a female 20 weeks presents with raised BP, gestational hypertension, and later if proteinuria occurs, it can be shifted to preeclampsia due to endothelial injury. Atherosclerosis and hemoconcentration occurs, and this leads to hemolysis, thrombocytopenia, and stasis of the blood. So this is Virchow's triad, where there is endothelial injury, hemoconcentration, and the platelet aggregation leading to thrombocytopenia. This can cause thrombocytopenia in the systemic microvascular coagulation can occur, and this can cause an organ damage.